today, but unfortunately, as things are at the moment, it's quite tricky. You haven't probably met me on the wards either, because my main work is mainly at the outpatients. So the topic I was given today was on thyroid endocrinology and investigations. And it sounds like a very wide topic. Thyroid is a quite large topic in endocrinology, but I will try to make it short, relatively short, and relevant to what you're doing on your everyday practice. And the way I'm going to structure today's talk will be about outlining basic thyroid physiology that will obviously help us understand the investigations and the cases I'm going to present. Starting with basic endocrine physiology that you all know, the hypothalamic pituitary thyroid axis is central to a normal thyroid function. The hypothalamus releases a peptide called TRH in the portal circulation. That stimulates the anterior pituitary to produce a glycoprotein called TSH that goes through into the main circulation to stimulate thyroid hormone production from the thyroid gland. And obviously you have a negative feedback from the periphery towards the hypothalamus, and the pituitary finally regulating the levels of thyroxine. The thyroid is comprised of spherical epithelial structures called follicles. In the middle of the follicle, colloid is contained, and the periphery of the follicle comprised of a single layer of cells called follicular cells. The follicular cell, as you might remember from your physiology, is central to the function of the thyroid. It's responsible for producing through the endoplasmic reticulum the thyroglobulin, which is the backbone of the T4 and T3 hormones. It's responsible for the uptake of iodine through a co-transporter into the cytosol and then into the colloid. And this is where, within the colloid, incorporation of the iodine to the tyrosine residues of the thyroglobulin occurs with the mediation of the thyroid peroxidase. So these mono and dio iodinazed tyrosine residues are linked to each other to form pre-hormones, precursors of the T3 and T4. So the large complex of thyroglobulin is endocytosed to the follicular cell, cleaved and released to the circulation. 80% of the hormones released by the thyroid comprise of T4, and the remaining is T3. And that equals to about 100 micrograms of thyroxine released every day, and about 35 micrograms of T3 released either direct production thyroid from peripheral conversion from T4 to T3. When T3 and T4 reach the plasma, the biggest amount of it is bound onto proteins. So 99.7% of T4 and T3 are bound onto proteins, predominantly by the thyroid binding globulin, by 7% that captures all the T4 and T3, and the remaining proteins are transthyretin and albumin. By definition, only the 0.3% of T4 and T3 are free in the serum, and this is exactly the bioavailable fraction of the total hormone, which is readily available to the tissues to uptake. So any abnormalities to the amount of proteins or to the binding of T4 and T3 on these proteins, including interaction with medication, has a significant effect on the thyroid function. When T3 and T4, the free fraction, reaches the periphery, the target organs, they have to go through a membrane co-transporter, And within the cytosol, they are either activated from T4 to T3 or deactivated to reverse T3. And again, there is a very fine regulation of activation versus deactivation with different iodinase enzymes acting depending on which peripheral tissue is receiving the T4. The activated T3 then crosses the nuclear membrane and binds into thyroid or hormone receptors bound directly onto the nucleic acid. We know that there are at least 4 different thyroid hormone receptors, namely beta-1 is the one met in liver and kidney, beta-2 in central structures like hypothalamus and pituitary, and alpha-1 in all peripheral tissues. When T3 is bound to the relevant elements on the nucleic acid, activates transcription factors, and as a result, a cascade of cellular events take place depending on the target organ. And before we start going through our cases, I thought I would just dedicate one slide to the thyroid function test, because out of all the investigations, what I really want you to understand and be able to interpret is probably not come under 3 main tests: TSH, a very screening tool, except from cases of pituitary disease, T4 and T3, which is usually not done in a non-specialty clinic. So TSH is a very reliable assay. In the event of discordance between TSH and T3, usually the TSH is the most reliable test to look at. The range that you see there on your screens is quite wide, and it's based on a range established based on wider population studies, and that doesn't really take into consideration factors like age, gender, ethnicity, BMI, iodine content in diet, and so on. So, for example, some studies suggest that TSH is allowed to rise in older individuals, although that observational studies that individual variation in TSH is quite tight. So your TSH is very tightly regulated and in a very tight range compared to the person sitting next to you. And that has an impact on how we interpret thyroid function, because clinical history is really important in interpreting these and making sense of them. Free T3 and free T4, as we previously discussed, is the free fraction of the hormone. And if you see the units there, they are in picomoles per liter. They are tiny, tiny amounts. We have really good techniques that pick up really small quantities, but still there can be analytical errors in the assays that we again, before going to the cases, that will be the centerpiece of our interpretation of TFTs today. This is a slide that has 7 hexagons in the middle and some associated pink boxes around them. And these hexagons represent different combinations in thyroid function. The very middle one is and T3 and T4 that fall into the normal range, and is associated with a TSH that also falls into the normal range, and we would call that normal TSH, the normal thyroid function test. The one over the middle hexagon is a pattern that is probably familiar to all of you. So when you have hyperthyroidism, either of thyroid origin or extra thyroid origin, negative feedback from that T3 and T4 will suppress the TSH. So it makes absolutely physiological sense based on the axis we previously described. The one right at the bottom, again, is a familiar pattern. When T3 and T4 fall from whatever reason, that creates a feedback to the pituitary and the hypothalamus to stimulate the thyroid to produce more, and as a result, you have a raised TSH. So the middle column of these hexagons make perfect physiological sense. Everything outside, right and left, is what we call discordant TFTs. So there are TFTs that don't quite fit with the clinical picture of the patient, and they don't quite fit with each other based on the axis rules that we described earlier. Our first case will be Mrs. SW. She is a 52-year-old lady who came through the acute take with pneumonia and heart failure. She had a lot of blood tests, and some of these blood tests were thyroid function tests that showed TSH in the lower end of normal range and a free T4 that was low. If you remember the previous normal range, I gave you 8.9 below normal range. But this is clinically euthyroid. So if we go back to the previous slide, this lady falls into the category of the left upper hexagon. So she's got low normal TSH with suppressed T3 and T4. And if you see the pink box linked to that hexagon, the differential diagnosis presented here is what we call non-thyroidal illness, central hypothyroidism, isolated TSH deficiency, which again either both central phenomena or ASSAY interference. So again, you need to evaluate and interpret your TFTs based on the clinical history. She is someone who came in acutely unwell, and she's otherwise euthyroid. So the main consideration would be towards non-thyroidal illness. So non-thyroidal illness is a term that you might have alternatively heard as sick euthyroid. We know it's an adaptive pattern of TFTs from studies in ICU. We know that almost 70% of ICU patients have abnormal TFTs. These changes can happen within 24 hours of the onset of the illness, and they can persist for weeks. Typically, as an adaptive response of the body to acute stress, you have a central suppression in TSH followed by suppression in T3 and T4. And one of the other things that the body does in the peripheries, it increases the deactivation of T4. So you have raised reverse T3. When the patient starts to recover from the non-thyroidal illness, the TSH starts to recover, and as a result, eventually T4 and T3 recover. And in the recovery phase, you can have a wide range of different combinations of T4 and T3 and TSH. And if that's the case, you just need to wait and reevaluate the patient. Other contributing factors to thyroid dysfunction in acute illness is medications, stress hormones, and binding to serum proteins. So in this lady, 6 weeks later, when things were repeated, TSH actually shot up, was above the normal range, and eventually 3 months later, everything was back to normal. I actually saw 3 patients in the clinic this morning, referred, all of them being acutely unwell in July with abnormal TFTs, referred to the clinic, normal TFTs now. So when you have an abnormal set of TFTs in your unwell patients on the wards, think of non-thyroidal illness. And instead of referring to us, maybe you can ask the GP to refer them, to repeat the TFTs and refer at the second stage if appropriate. Case number 2, she's Mrs. DT. She's 51 years old. She has a history of bipolar, previously treated with lithium. She's got a history of hyperthyroidism, possibly Hashimoto's. Obviously, lithium can have an intrinsic effect on thyroid function. This lady is also obese. She weighs 198 kilograms. The GP tried increasing doses of levothyroxine, actually reached a dose of 400 micrograms. And by the time she was assessed at the clinic, she was on levothyroxine 300 micrograms with a really high TSH, a normal T4, and vitamin D that was low. On asking her about compliance, she was adamant that she's been compliant, and in terms of taking the thyroxine as instructed on an empty stomach and allow 30 to 60 minutes to absorb, she assured me that that was the case. And she was clinically euthyroid. And again, going back to this slide, which I find really useful, this lady falls into the left bottom hexagon. So she's got normal T4, T3, and she's got a raised TSH. The differential associated with this hexagon is subclinical hypothyroidism. We know that she's got hypothyroidism. For compliance with thyroxine, that's a possibility. Malabsorption of thyroxine, that's a possibility. She has a low vitamin D, but obviously vitamin D doesn't only rely on absorption. Interferon medications, there's nothing obvious there. ASSAY interference, perhaps. Non-thyroidal illness recovery phase, she didn't report any recent illness or TSH resistance, which is rather unusual. So, because that was her second time referring to the service, to the endocrine clinic, I thought I should exclude a TSA-ASSAY interference. These days, we have really clever ways of detecting hormones. So one of them is called immunometric. So that relies into a sandwich technique. You might remember it from medical school. So the analyte in this particular occasion, this is the TSH, needs to be sandwiched between two different antibodies. The first antibody is called capture antibodies in the solid phase. The serum of the patient is added to this solid phase antibody, and then in a second step, a second antibody is added, which is labeled these days labeled with fluorescence. So when you have binding of the fluorescent antibody to the analyte, there is light emitted, and from the detection of light, that can be quantified into hormone concentrations. Antibody techniques, unfortunately, are in a way, you can have antibody interference affecting the reliability of these assays, and there are a number of antibodies, including analyte-specific antibodies or human anti-animal antibodies or heterophile antibodies, which are mainly polyclonal non-specific antibodies that can actually produce a positive or a negative interference. And there are ways of dealing with that. When it's suspected, we can use a different assay that uses different antibodies. We can remove these interfering antibodies by precipitation or dilution. And sometimes if anti-animal antibodies are suspected, we can add animal serum, commonly it's anti-mouse or mouse serum, into them to mop out the antibodies and resolve the interference issues. So there was no TSA interference issues with this lady. The next thing that can be considered is whether there is an issue with thyroxine absorption. Again, this lady is 198 kilograms. She is not very obviously malnourished. She didn't have any other malnutrition markers. Commonly, I do a celiac screen. I check things like B12, folate, ferritin, so just do kind of generic absorption screen. She didn't have any of that. She was vitamin D deficient, which is very common. Obviously, absorption cannot necessarily be related to that. So you either have general malabsorption, or there are some studies suggesting that thyroxine malabsorption can be specific for thyroxine. And these particular studies essentially imply that, for example, factors like gastric pH is really important. And if you, for example, provide to the patient H. pylori eradication, you can treat their thyroxine malabsorption and hence their hypothyroidism. I think, again, that's an area which is not very clear to us. But some centers do they do a thyroxine absorption test that comprises of giving a big weekly dose of 700 micrograms of levothyroxine in one go, and then measure TSH T3 T4 every 30 minutes for 120 minutes, and then by using a complicated formula calculate how much thyroxine is absorbed. Commonly, there are some issues with absorption with thyroxine when instruction to taking the medication are not followed. So we know that about 50 to the absorption of thyroxine can vary between 50 to 85%, and having it on an empty stomach and allowing 30 to 60 minutes to absorb really does help with any absorption issues. So I never had to do the absorption test. Just, as I said, usually do the general kind of malabsorption screen. And if I'm satisfied that that's not the case, I just don't do it. So what I did in her case, I just gave her a bigger dose of levothyroxine. So the way of dosing your patient with levothyroxine, the kind of per weight dose we use is about 1.6 micrograms per kilogram. Again, there's a suggestion that in fact, overweight and obese patients need less. For example, for someone with her BMI would probably need about 1.27 per kilogram. I gave her more than that. And the rationale behind it was that a lot of people won't admit to non-compliance. So by giving them a bigger daily dose, you're hoping that if they take 3 or 4 doses per week reliably, that will be sufficient to suppress the TSH. And this is exactly what happened. The TSH came down from 32 to 5. And I don't think there was anything but compliance issues in this particular case. And this is a similar case of someone who essentially didn't take her medications. And I want to emphasize that with your patients. So in terms of confrontationally asking the question, do you take your thyroid? I would probably adopt a more sympathetic approach to say, how do you take your thyroxine? And that usually generates a discussion about how they take it and any struggles that prevent them from taking it. And at this point, a lot of people will admit of not taking it, and that will solve a lot of the analytical or other issues we mentioned earlier. Next patient, Mrs. AS, 39 years old, history of follicular. I think it jumped one. Give me just 1 second. Yeah, 39 years old, a follicular thyroid cancer. She had a total thyroidectomy in 2018. And this is the lady who had 4 children, single parent, a full-time job, and essentially admitted that I can't take my thyroxine. And we talked about it, and we found a way of practically incorporating thyroxine into her daily routine. So case number 4, Mrs. RN, 73 years old lady, history of subclinical hyperthyroidism for almost 20 years, congenital heart disease and osteoporosis, suppressed TSH, normal T4, T3, positive antibodies. Commonly elderly people with thyrotoxicosis will do an uptake scan to see whether there's any autonomy there, and I'll talk to you about these scans in a minute. And she had no autonomy. So the history so far is of an elderly person with autoimmune thyrotoxicosis. And again, looking back to our kind of centerpiece, the hexagon that she falls into is the upper left one. So normal free T3, T4, and suppressed TSH, so subclinical hyperthyroidism. This is where she belongs. Recent treatment for hyperthyroidism, drugs, no interfering drugs, S interference, no, and she's been well, so non-thyroidal illness is not suspected. And really, the reason I'm describing this case is not because there was dispute of what is the actual diagnosis. It was more about talking a little bit about autoantibodies. So the two main autoantibodies we use is that TSH receptor antibodies that can be stimulating or blocking, and the anti-TPO antibodies. TSH antibodies are very specific for Graves' disease, and 100% of Graves' disease patients have them. Anti-TPO antibodies are non-specific. They're very common in Hashimoto's, but it's very common in normal healthy population. Over 10% of healthy population are positive for TPOs. And the interpretation of TPOs, and the only reason you should be doing them if you suspect thyroid disease, is you need to interpret your TPO antibodies on the clinical context. So gender is one of the risk factors. So female, and being female and having positive antibodies increases your risk of hypothyroidism. Other factors like symptoms, borderline TSH, goiter, or family history, again, in relation to a positive anti-TPO, increases your risk. And this is something that we can highlight to the GPs, asking them to yearly check a thyroid function test in these people, and obviously if they become overtly hypothyroid, to treat them. Now, subclinical hyperthyroidism is really a misnomer in a sense. By definition, it implies that it's there, but it doesn't cause any troubles. But we do know from, again, clinical studies that subclinical hyperthyroidism is associated with dysrhythmias and also low bone mineral density. So if you remember one of the very few slides talking about the normal range in TSH and T3, T4, the individual variation is quite tight. So something that falls outside the normal range for the wider population can be really abnormal for this particular individual. And someone who has been sufficiently disturbed from a thyroid perspective to suppress the TSH, it means that, in fact, in a cellular level, they are thyrotoxic. They are trying to reduce the amount of TSH they are producing. This is the negative feedback their pituitary is receiving. And again, treating these cohort of patients, you need to be mindful that there are certain criteria. You don't need to remember any of that, but age, a reduced bone mineral density, history of dysrhythmias, and any autonomy are important factors to make you decide whether these people with subclinical need to be treated for a clinical condition. Next case, Mrs. BP. She is 87 years old. She has a history of multinodular goiter with a retrosternal extension. She has a T3 toxicosis, and she has history of atrial fibrillation. She's on treatment with a carbimazole. The carbimazole is an anti-thyroid medication. It blocks the thyroid peroxidase, rendering the thyroid less capable of producing T3 and T4. Kind of borderline thyrotoxicosis on treatment. And she had an uptake scan, as I said previously, a nodular thyroid in an elderly patient, especially with thyrotoxicosis, implies an autonomous nodule. And this autonomous nodule can be picked up with what we call a thyroid uptake scan. I just want to highlight one thing to you. It's the T3 toxicosis. For whoever hasn't heard this term before, essentially it means that your T4 is normal, your T3 is elevated. And in autonomous nodules, sometimes we see, although obviously they are benign, well differentiated, a hyperfunctioning adenoma, sometimes their function can divert from normal thyroid tissue. So the ratio between T4 and T3 can be different. And as a result, they have a T3 toxicosis rather than T4, T3 toxicosis, as you would typically see in a Graves patient. And this is her uptake scan. So in a normal uptake scan, you can see very beautifully the thyroid anatomy with the two thyroid lobes and the isthmus. When a thyroid nodule is present, it means that it overtakes control. This is the dominant area that produces T4 and T3, and because of negative feedback to the pituitary, you have no TSH to stimulate the normal thyroid parenchyma, and as a result, you have just one hot area, and the rest of the thyroid parenchyma remains silent on the uptake scan. The uptake scan we use in this hospital is based on an isotope called technetium-99m. You don't need to stop the patient medications to do the scan. It can be given IV, and it allows a rapid scanning time. So within 30-60 minutes, you can have your pictures. So this particular patient, so whoever has a thyroid nodule on uptake scan, this is a great target for what we call radioiodine treatment. So we give radioiodine, which concentrates preferentially in the autonomous nodule and causes destruction of the nodule and resolution of the thyrotoxicosis in the majority of patients. Before we give this treatment, especially if the patient has a retrosternal extension of the goiter, we need to assess the impact of that goiter onto the trachea. So normal trachea diameter, 15 to 25 millimeters for men, about 10 to 20 in women. Critical stenosis, anything below 5 millimeters. These are all anatomical information we can very accurately have with CTs these days that obviously have high resolution. They're very accurate. You might come across the flow volume loops as an alternative way of assessing these tracheal stenosis, and you would remember that it's not something that we use very much anymore, because obviously CT quality has improved a lot. And again, there are studies suggesting that it has no impact on decision making. Case number 6, Mrs. LH, recently seen in the clinic. She's 23 years old. When I saw her, she was 21 weeks pregnant with her first child. Presented to her GP with rapid neck swelling. She had a normal TSH and she was clinically euthyroid. And on ultrasound, that would be your first line for any palpable nodules, showed almost 2 centimeter nodule that was classified as a U3. And I will explain that to you in a minute about the classification, but a U3, it means that's an intermediate indeterminate in terms of malignancy. Anything above U3 needs to be FNA'd. So the FNA showed Phi3F. F stands for follicular, so it's a follicular lesion. With follicular lesion is quite difficult to, especially with FNA, that you really get a few cells to establish whether this is just a hyperplastic nodule with lots of follicular cells, or an adenoma, which is a benign growth, or a carcinoma. So with at the moment she's 29 weeks pregnant. She has gone past her second trimester. This has been referred to the MDT to see what the next step will be in her management. And nodules, thyroid nodules, are common. After a certain age, almost 15% of the population has one. The majority of them are non-cancerous. And when you assess a patient with a new nodule, things like age are important. So young people below 20 or old people over 60 have a greatest likelihood for malignancy, rapid enlargement, family history, especially MEN1, presence of lymph nodes, and history of radiation. They're all important when you're assessing your patient. And this is her ultrasound. So this is a 2 centimeter nodule, and it's quite hyperechoic, who's well circumscribed, it's got a halo, and it's got mixed vascularity on the Doppler study. In this country, we use the British Thoracic Society guidelines for ultrasonographic classification of thyroid nodules from U1 to U5. U1 is benign, U5 is malignant. Everything in between is increasing likelihood of malignancy. So the U3 that CIS had was indeterminate in that respect. In America, they use a very similar system called Thyroids. Her FNA, we showed a follicular lesion, as we discussed previously. Anything of indeterminate potential based on ultrasonographic criteria is FNA'd. And again, the FNA histologies are classified into 5 categories. Thy1 is non-diagnostic, Thy2 is benign, Thy3, 4, 5 are increasing likelihood of malignancy. Mrs. MG, she's 35 years old. She presented with history suggestive of hypothyroidism. She's got a TSH of 82.3, a raised T4, and raised anti-TBOs antibodies. Looking at this, I just want you to think how important clinical history is. So as you probably see, something doesn't quite make sense in this one. So the suggestion based on the histories of hypothyroidism, and we need to work towards that. So clinically she's euthyroid, so the TSH makes sense. What doesn't make sense is her T4. And the hexagon that she falls into is the right lower one, so raised TSH, raised T4, T3. And the differential here is quite interesting, it's one of my favorite. So S interference, one of them, thyroxine replacement. She hasn't tried any thyroxine drugs, interfering drugs, she wasn't on anything. Non-thyroidal illness, is not unwell. Neonatal period, she's not a baby. TSH secreting pituitary adenoma, quite rare, but if that's the case, she should be thyrotoxic, she's not. Resistance to thyroid hormone, again, I'll talk to you in a minute about that. That is associated with thyrotoxicosis rather than a hypothyroid picture. And disorders in thyroid hormone transport or metabolism are quite rare as well. So, so TSA interference was top on the list, and T4, T3 is measured in a very similar way to the TSA assay we described earlier. So immunometric sandwich technique, you need 2 antibodies, one capture in the solid phase, one in the kind of liquid phase, which is labeled, and the emitted light is measured and quantified. Again, these sort of assays are prone to analytical errors. Interfering antibodies, as the ones we mentioned before, can interfere. And when a different assay was used, the TSH was consistent with the previous TSH and with her clinical picture, and her T4 was again within that made sense in that clinical context. Now, staying in the same differential diagnosis box, so the one on the right, lower corner, I'm going to talk to you about TSHOMAs and thyroid resistance. These are rare things, but I would like you to be aware of them rather than know everything about them. So TSHOMA is a rare tumor. Out of all the pituitary macroadenomas, 2% of them are TSHOMAs. Because they produce too much TSH, if you remember, again, your HPT axis, it leads into increased production of T3 and T4. And as a result, you get a thyrotoxic picture. These people are thyrotoxic, but from a central cause. There are ways of distinguishing TSHOMAs from thyroid hormone resistance. So although they are benign, well-differentiated adenomas, they still have diversion from normal pituitary function, and then don't quite respond to blocking or stimulatory tests with T3 or TRH. Now, thyroid hormone resistance is a rare condition. The most common type is when there is a mutation in the beta-2 thyroid receptor. If you remember, this is the centrally located thyroid hormone receptor. So this is the one that sits in the pituitary and the hypothalamus. Depending on the severity of that mutation, renders the pituitary quite insensitive to the peripheral feedback from T3 and T4, meaning that although you have perfectly normal T3 and T4 in the periphery, that's not quite perceived as such by the pituitary, and as a result produces more TSH and more T3, T4, creating a thyrotoxic state. If the mutation is not centrally but peripherally, so you have insensitive peripheral tissues, then you have a true tissue hypothyroidism. I think that's the last case. So this is Mrs. H.C. She's 36 years old lady. She has history of hypothyroidism. She's treated on appropriate dose, but she's still having symptoms suggestive of hypothyroidism. TSH is exactly where it should be, 1.45. T4 is, again, as you would expect it, 13.1. Why is she symptomatic? And this lady actually falls into the middle hexagon. This is where we started from, saying that this is the hexagon that represents normality. T4, T3 are normal, TSH is normal. So the patient should be feeling well, but she's not. And that comes back to the way we interpret TFT. So as we said, a laboratory range based on a wider population might not quite agree with individual range in TSH or T3 and T4, meaning that although this lady in a population level falls within limits, she might be her thyroid function test is perceived as reduced by her body. And what I tend to do with these people, with these patients, except from the T4, I do a T3 to see whether there's a conversion issue, because obviously you expect the T3 to be the active element. And I usually increase the levothyroxine dose to bring that T4 in the upper normal, up at the upper end of normal range, even if I have to suppress the TSH a little bit more. And I have a very honest discussion about this with the patient, saying, well, ranges are not absolutely accurate for everybody. Assays are not, again, 100% accurate. There's a lot of things that we still don't know about the cellular events of T3 and T4. There's definitely a large number of patients on replacement complaining of ongoing symptoms, although they are biochemically euthyroid. And part of this discussion would include about managing expectation and saying, well, there's still just one medication that we can give you, levothyroxine. There's a lot of dispute about treating these patients with T3. T3 comes under liothyronine. It's given 3 times a day. It's really short acting. It creates large peaks and troughs during the day. It's not really a physiological pattern, and this is not something formally advised anyway, so we don't tend to give our patients liothyronine, although some people do improve on liothyronine, because obviously probably brings the ratio of T3 and T4 in a more normal range. So in conclusion, what I would like from you to take away today is perform TFTs in people that need them. Ask the right questions, and if you suspect thyroid dysfunction, order your TFTs. There are going to be a lot of non-thyroidal illness patients with thyroid dysfunction, and you need to be aware of that. And don't rush to treat them or misinterpret and make a diagnosis. You always need to evaluate your clinical history in relation to your blood tests, parameters like age, pregnancy status, concurrent illness obviously needs to be taken into consideration. Commonly, give yourself a little bit of time to think. So repeat the thyroid function in a later stage if you're not sure. Ask somebody, obviously, we're allowed to be asked. And again, if the patient needs treating because she or he has a persistent picture, then to think, why are you treating, how are you treating? Can it be one of the uncommon causes that we have already mentioned? So I'm going to finish this presentation with a slide. I would like to thank you for listening to me. It's been a quite long presentation. I just hope that you found it helpful, and I'm open to any questions if there are any. Thank you. Everybody's really quiet. Should I assume that there are no questions?
Yeah, I think so. I don't have any questions, at least personally.
Thank you. Thank you. Okay, so hopefully we'll meet in person in the future. Hopefully after spring we'll have the vaccine and everybody will be a lot happier. And teaching will just be as we're used to be delivering it. Okay, thank you very much. And yeah, hopefully I'll see all of you soon. Thank you. Bye.
Thank you very much for your time today.